Well, good afternoon, everyone, and thank you for attending another one of our Transplant Institute Grand Rounds. I'm Marwan Abuzud, Director of the Transplant Institute, and it's my pleasure to welcome today one of our friends and colleagues, Dr. Denise Simpson, who comes to us from Northwestern Comprehensive Transplant Center in Chicago. Dr. Simpson is now the Chief Health Equity Executive. This is a new role that she took on in Northwestern Healthcare, and she's leading initiatives with her team of over 50 individuals to develop patient-facing health equity initiatives that will extend beyond what she has started there as the founding director of Northwestern Medicine African American Transplant Access Program, which has received national accolades and is being duplicated now in other centers. She is also the Vice Chair of Faculty Development and Diversity and the director of the program that I just mentioned. Dr. Simpson graduated from Colgate University for undergrad and worked in the research analyst, where she was researching patient-facing healthcare search initiatives and looking at ethnicity and culture, how they influence opinion. And she went on to medical school at NYU with a transplant surgery fellowship at Penn before she went back to Northwestern in her current role now. I've known Dr. Simpson for many years, and it's been a pleasure to work with her side by side as our society, the American Society of Transplant Surgeons, went on a journey of diversity, equity, and inclusion. And as such, she was the inaugural Diversity, Equity, and Inclusion Advisor for the ASTS and served on the board at that time, and chaired the Anti-Racism Task Force, which was during tumultuous times, but yielded significant change in the fabric and the policies of our society. And more recently, she was awarded the Diversity Award by the Society, and currently she serves on the ASTS Board of Counselors. She's received numerous awards, too many to cite. However, some of them are quite intriguing. The Distinctively Me Community Shiro Award. I did not know there was a Shiro. I finally realized that the hero is kind of like imbalanced a little bit. And the NKF Rising Star Award, as well as the NYU Alumni Changemaker Award for those who are innovative and entrepreneurial in the spirit of the greater good, and also the Fierce 50 Honoree in Healthcare and Diversity. It is my utmost pleasure to bring to the podium my friend and colleague, Dr. Denise Simpson, who will talk to us today about transplant health equity in action, moving disparities research from bench to the bedside. Dr. Simpson.
Thank you so much. Thank you, Dr. Abujud. Can you guys hear me okay? And are you able to test to see if they can hear me online? You think you can? Okay, all right, great. Okay, excellent. Well, I am very, very excited. This has been a visit long in the making, and because of COVID and various other things, I couldn't get here, and so glad to finally be here today to talk to you about our transplant equity journey at Northwestern. I have no disclosures, in our work, I am proud to say, is now NIH supported with NIH U01 grant. So I like to start this discussion with this quote from Dr. Jewel Mullen. And I think that I'm preaching to the choir here. I think that you all have experienced this, but what she said to the AMA some years back is that in the United States, the pathway to organ transplantation is complicated, full of potholes and that impede access, and riddled with crevasses into which people fall and never emerge. And I think in talking with Dr. Abujud this morning about the demographic of patients that you serve here and the different socioeconomic barriers and challenges that patients face here, you guys have undoubtedly witnessed this for your own patient population. And so what I am endeavoring to do with you all this morning is just to tell you a little bit about my journey in Chicago. And so I have some objectives. I would like to first level set whenever I talk about health equity. I always make sure that we're all on the same page in terms of definitions. And so we'll just spend a few moments just aligning on the definitions that I use when I talk about health equity and racism. Then we'll take a little virtual map tour of Chicago, and I'll show you how Chicago is set up to really see health inequities play out, but also creates a great setting for us to have some interventions and see some success with those. And then we'll translate. And so, you know, in academic medicine, I think we're all challenged to have some type of academic shtick, if you will. What are we going to do to further medicine, to further science? And so the one thing that I found, particularly in the health equity space, is that we have a lot of literature that already describes the problems that are out there. And so I felt quite personally that in order to get started on the intervention side of things, I didn't necessarily need to spend a whole lot of time contributing to the literature to start, because the descriptions were already there. And so I'll tell you guys how we translated the already existing literature into an intervention. And then finally, throughout this talk, I hope to motivate and use this work, this presentation, as a call to embrace this type of work, which I know is not going to be hard work in this audience, because you all are already doing this work already, as Dr. Abeljoud let me know. So those definitions, as I promised, and I'm going to move a little quickly because I want to try to make sure we have some time for questions. There are a lot of different definitions of health equity out there, and I think that it's important to make sure that we're all on the same page in terms of definitions. One, because there's so many different definitions out there, and two, because there's so much misinformation and disinformation with our current socio-political state. And so a lot of the terms that we use have become very stigmatized, very triggering. And so I just try to, you know, take some time to level set here. So the health equity definition that we are aligning with is the American Public Health Association definition, which is everyone has the opportunity to attain their highest level of health. Now that's further broken down into two buckets, and I think it's very important to spend a couple of moments here. Healthcare equity is another term we hear, and many times it's used interchangeably, but it's actually not exactly the same. And what healthcare equity is it's something that's measurable at the individual level. So you can think of that as what happens once patients are within the four walls of Henry Ford Health System. Okay, that's something you can measure at an individual level, and that's something that your health system can directly impact. That's only one part of health equity, and many of you have probably heard the stat that only 20% of someone's health it happens or is affected by what's within your four walls. The other 80% happens outside, and so that's where that societal and structural equity piece comes in. That's a little more challenging to move the needle on, okay? So that's something that's measurable at the community level. And so in order to move the needle on that, we really need to be part of a multi-stakeholder approach. We need to partner with entities outside of our health system, with community partners, community organizations, to really see impact at that level. And together, those really are combined into creating or achieving health equity for our patients. I'll spend a couple moments on race. You know, hopefully we all know now that race is really a social construct. It's not really linked to genes. And in fact, although our visible traits are influenced by genes, the vast majority of genetic variation, as it says here on the slide, exists within racial groups and not between them. And so that's just one thing I like to lay out as we embark on this journey. And then finally, the different types of racism. I don't have to tell you guys that racism is a very charged term, and actually in many academic institutions, there's been a movement to move away from using those terms. The way I like to describe it is that racism is just like an itis in medicine, right? So we talk about appendicitis, cholecystitis. It's an inflammation. There's a problem with whatever the beginning part of the word is. And so ism is just an inflammation that has to do with race. And when I say that, I feel like it makes people feel a little more comfortable when we use the terms racism. And for the purposes of this talk and for health equity, we're not talking about interpersonal racism, which is that sort of one-on-one personal beliefs type of racism. We're really talking about the institutional racism and structural racism. And so the definitions that we align with there for institutional racism, policies and practices within and across institutions that intentionally or not produce outcomes that chronically favor or put a racial group at a disadvantage. And then finally, structural racism is the mechanisms by which societies foster discrimination through systems of employment, housing, education and income, healthcare, and criminal justice that will either reinforce discriminatory beliefs and values and the distribution of resources. Okay, so these are those inflammations that I'm speaking of that can really put a particular group at a disadvantage. So I want to spend a couple minutes just to tell you a little bit how I arrived at this space. Okay, so when I was a trainee in Boston, I trained at Brigham and Women's Hospital, and I was rotating on the transplant service. It's really kind of an apprenticeship model. There's only one resident on the service, and we would work closely with the transplant surgeons. And so my first day was in clinic. And in that clinic space, the way we had it set up, I would go see the patients first, and then the attending would come visit the patient. So I was the first point of contact for those patients. And all the patients that we happened to be assessing that day in Boston were African American, which really just struck me. Nowhere in my healthcare education, my medical school training, had I really been taught about disparities. It wasn't part of medical education then. I think a lot has changed over that time, but it just caused me to kind of take a step back and question what I was seeing and why I was seeing it. And what further impacted me that day was how the patients responded to me. And all the patients responded to me in a way that I'd never experienced before. And I realized that I was doing something for those patients just by looking the way that I looked. I hadn't offered them any medical care. As a matter of fact, I took special care to let them know that I wasn't the boss and that I was just the trainee, but that didn't matter. And I had patients hug me, people, perfect strangers. I had people cry, tell me they were proud of me, tell me that, it made them feel some sort of way by me coming in the room and being the first Black physician that they'd ever seen. And so that really impacted me. After that clinic day, I went to the literature because I needed to know why that evaluation day was 100% African American. This was a kidney transplant clinic. And I learned quite a bit. And so, I learned that kidney disease in the United States is the 9th leading cause of death, that there were, 100,000 new, and this is more contemporary data, but I don't think it's changed much over the time, 100,000 new to dialysis every year, knowing that 60% will die within 5 years, and that African Americans are 4 times more likely to develop kidney disease. The census tells us that we represent 13% of the patient population. I think it's a bit more than that, but even though the data tells us we represent 13% of the population, we represent 35% of those suffering from kidney disease. So that represented to me a real problem. And further research, into the literature showed me the reasons why we're seeing these types of numbers. And a lot of these are modifiable things, or things that are in our environment, things that are related back to those structural and institutional racism that I defined on the previous slide. So several years later, I ended up in Chicago, and I wanted to make a difference in this space. I had written my personal statement to fellowship about creating an intervention that somehow moved the needle on those numbers that I just showed you on the previous slide. And so we're about to take this little map tour of Chicago. And for those who haven't visited, one thing I love about Chicago is it's a wonderfully diverse city. And if you look at our census data, we're roughly a third white, Black, and Hispanic, and about 6.1% Asian. And then we have some smatterings of other groups represented in there as well. But the one thing, despite us being, diverse on paper, we're actually a very segregated city. And so when you look at a map of Chicago, you start to see how different inequities play out. And so this is a map of Chicago. And for the purposes of this demonstration, or this map tour of Chicago, I want you to focus on the green. The green on the west and the south side of the city represents our African American community. So you can see that they're mainly clustered in one area, representing that segregation that I spoke of. Now, keeping those areas in mind, let's look at food deserts in the city. And so when you look at the brown areas, and this is by county, this is divided up by our zip code, zip code in Cook County, you can see that the majority of our food deserts are focused in those Black and brown communities on the west and south side of the city. And as a matter of fact, 80% of Chicago's food deserts are in Black and brown communities. So not surprisingly, when you then look at CDC data, and this is from their 500 cities project, hypertension, diabetes, obesity are also going to be hotspots on the west and south side of the city. Now, I chose to highlight hypertension and diabetes because when I tell this story, I tell it from a lens of kidney disease. And so obviously those are the top two causes of kidney disease. And so you start to see how these things develop. And this is some of that structural racism that I referenced in our definition slides. And you can see this coming to life. Let's talk a little bit about resources in these communities. So these communities are not just food deserts, they're specialty deserts, they're pharmacy deserts. Too many slides for me to put up here and on one slide here, but for the purposes of this presentation, I chose nephrologists and dialysis. And so this doesn't project very well, unfortunately, but I'll tell you what you're seeing. You're seeing, again, dark green boxes, which represent our Black and brown communities on the west and south side of the city, and a concentration of dialysis centers in those communities. My patients will joke with me and tell me that they give directions based on DaVita dialysis centers. You know, when I lived in Boston, we used to joke and say that you could give directions based on Dunkin' Donuts. But in these communities, it's based on dialysis centers. And so the patients say, I tell my friends, go down 2 blocks until you see the DaVita, take a left, go down till you see the next one, and that's where you'll find X, Y, or Z. And, my patients will ask me and be like, Dr. Simpson, why are there so many dialysis centers in our communities, but you can't find a grocery store? You can't find a nephrologist outside of a dialysis center. So what this slide also shows you is that there are red squares, and there are very, very few of those. Those represent nephrologists in these communities where kidney disease the rates are the highest. And so this represents a specialty desert. And so when you pull all of those slides together, it's not surprising to find then that there's a life expectancy difference in these different communities. And so when you look let's see if my arrow shows up, it does. This area here, this sort of light grayish blue area, that represents the Gold Coast or Streeterville. That's actually where Northwestern's main downtown campus is. If you were to look at life expectancy in that very affluent neighborhood and compare it to our neighborhoods on the west and south side, there's a difference of life expectancy by 30 years. And that's not just explained by violence, as people like to sort of chalk it up to. It's explained by all these different things that you see here on this slide. The literature tells us more about why we see the stats in kidney disease in the African-American community that we do. The literature tells us that Black patients are less likely to be informed on their risk and less likely to be screened. They have lower referrals to nephrology and transplant. They're less likely to complete an evaluation once they finally get through our doors, and less likely to be listed. And then once they are listed, they're more likely to wait longer, more likely to be delisted and not reactivated. And then, of course, they're less likely to have an eligible living donor. So these are more of those institutional barriers. I showed you structural barriers. These are now our institutional barriers at play. And this is from a paper that we penned to AJT, looking at the impact of societal and structural inequities in the height of COVID, and also looking at it with kidney disease as well. This is me and Tangela Purnell put this together, and great to work with her on this. But what we did is we kind of showed this as a leaky pipeline. And so essentially you have this huge population that's at risk. And as you move down this continuum towards, further development of kidney disease, more and more people fall out of this pipeline into chronic dialysis, and less are getting the treatment that they need, the gold standard of treatment. So all that is to say is that access to transplant does not mean that you have transplant equity. Just having our doors open and saying, hey, all can come to Henry Ford, all can come to Northwestern, doesn't mean that that's where the work is done, okay? So now let's transition to some of that translation piece of the talk. And so how do we take the decades worth of literature out there describing disparities and turn it into action? And so what I like to start with is looking at this, this framework, or this model rather, of the health equity tree. Some of you may have seen it before. I think it's brilliant. I can't take credit for this. This is not my work, but I think it's a great way to demonstrate where we should be having impact, or where we should be trying to have impact, and the scale of the results of that impact. So what we see when we think about healthcare equity, remember that's what happens in our four walls once patients actually come into our health system. That's really what we see in the leaves and the branches of our health equity tree. These are our outcomes and our health behaviors. But what we need to recognize is that those outcomes and behaviors are influenced deeper down by the roots of this tree, and these are more of those societal and structural barriers. And so this is, really look at racism, poverty, policy. We look at our social determinants of health, which has now become part of our day-to-day lingo in our medical training. And if you can have impact down here at the roots and at the trunk of the tree, then you can really make a huge difference at the level of these behaviors and outcomes. I think traditionally what we've been kind of trained to do is to think within our four walls. And so, okay, we see a patient come in with, say diabetes. And so we counsel them on the importance of healthy diet, on the importance of, reading food labels and this and that. And so for that one patient, we may make a world of difference, but we're really not getting at the roots and at the tree. But if we can get at the roots and the trunk, then we can have a larger scale impact. And so what I show that here. And so the individual advocacy, that one-on-one impact with patients, very important again. So I'm not saying leave that behind, but when we start looking at making single-armed or multiple-armed intervention, then we can reach a larger population. Then obviously, if we have structural and policy change, looking at some of those structural and institutional policies, then we can, affect a large group of people. So as we were embarking on our journey at Northwestern, I questioned, where can we have the greatest level of impact? I realized that as a single institution, we probably wouldn't be able to change much in terms of structural and policy change, at least not alone. We can partner with other individuals and other groups to do that. But where we could probably see some immediate impact is by creating either a single intervention or maybe even a multiple intervention program. And so that's what we decided to do. Looking at transplant as a continuum, starting with screening and diagnosis for disease development. As disease develops and you move along this continuum, eventually to transplant, and then looking at post-transplant outcomes, we decided to focus right here. And so what this correlates to when we look back at that leaky pipeline that I showed you in previous slides, this is really where we're focusing. Obviously, if we were thinking about policy change, then we could really get this whole pipeline in the picture. But being realistic about what a single institution could do, we decided to focus right here. So we're looking at referral, listing, and then transplant itself. And so this really looks at, how are we interacting with communities, with referring providers, with trusted sources in the African American community, some of our largest Black churches, educational system, and things like that, to get patients educated and referred. Then looking internally, what are we doing in our committee room when we're talking about listing patients? Are we looking at ways that patients don't qualify for transplant, or are we looking at ways that they can become transplant candidates? So kind of changing the culture in the committee space was something that we are trying to do. And then, working with our patients on things like adherence, other barriers that they had, getting them to actual transplant. And then hopefully in the future, expanding our efforts to be able to support patients more on the post-transplant outcomes side of things. And then, of course, inserting ourselves more into policy so that we can have a broader impact. The way we started, again, is that I felt pretty strongly that if I had to go back and redefine the problem, that would put me 10 years down the road before we could actually create a program. And the literature was there. So what we did is we pulled all the papers that were ever written. We reviewed all the abstracts, read many of the papers in depth, and created a list of all the disparities that were described in the literature for access to transplant for the African American community. And then we further divided those barriers into what is modifiable, what's not modifiable at an institutional level. Some things that are related to policy change, we felt like we couldn't modify. Some things that are related to the patients themselves, vascular targets, other comorbidities, a little more challenging for us to impact. But things that we could impact, we wanted to create a program around. And so what we ultimately ended up with is a 4-pillared program. And so distrust was something that was mentioned again and again in the literature. And so we decided to create an intervention that re-earned trust with our patients. Health literacy is a common barrier, particularly for communities of color. And so we created an intervention around that. And I'm going to go into each of these in a little bit of detail in a moment. Psychosocial barriers, I think, is the biggest piece of all. And this is a broad umbrella that encompasses a lot of things: insurance issues, transportation issues, social support issues. And so we have a dedicated social worker who helps our patients with that. And then finally, kind of under at the foundation of all that is cultural congruence. And so we have made it a point that in our program, at that first intake visit, our patients are seen by culturally concordant, racially concordant providers. Obviously, as they go through the rest of their transplant journey and have to see different specialists, get their cardiac clearance, see this person, that person, they're not going to have or be guaranteed that racial concordance, but we wanted to guarantee it at least in that initial visit. And that's based off literature, which I will review in a coming slide. And so this is our program, the African American Transplant Access Program. From here on out, I'll call it ATAP. It's a mouthful, but this is how we structured it. So let's first talk a little bit about distrust and why we chose that. Again, that's something that showed up again and again in the literature, and something that I've heard or been questioned on is, well, why is the Black community so distrustful? For those of us who know our history, we know that American history has built a foundation for distrust, and these pictures just show a few reasons why patients are distrustful. What I find very interesting about these pictures is they're all in black and white. The one here in the middle is pictures of the Tuskegee syphilis study, and the black and white makes us think that was really, really long ago, but this is something that's recalled by my parents and their grandparents. This is, stories that were told in my household as I was growing up. This is recalled to this day as I struggle with my own parents, to get them to trust certain medical advice and to be adherent to certain treatment plans that are prescribed to them. And so although these pictures are in black and white, these are, very much present in the memory of our patients. And then, of course, there's other stories that I couldn't even fit onto this slide of medical mistreatment, and then there's personal stories as well. And then you mix with that misinformation and disinformation, and so you have this real challenge in earning trust and being able to connect with our patients. How do we impact that? Like, how do we move the needle there? And so what the literature will tell us is that racial concordance can really build trust. Language concordance can build trust. At Northwestern, we also have a Hispanic transplant program that's centered on language and cultural concordance, and they have a wealth of data showing how that has really made a difference for that patient population. And so I just highlight 2 studies here. One is from JAMA, where they looked in some of the most impoverished communities in the United States and looked at Black representation in primary care workforce, and saw that at every level of income, that having Black representation improved life mortality. And then the study here on the other side of the screen is a study that was out of California, where they took a cohort of Black men who were going to be screened for things like blood pressure, weight loss, smoking cessation, vaccination, and asked them before the intervention how likely they would be to take advice. And then they randomized them to a racially concordant provider or one who wasn't racially concordant. And they found that patients that were randomized to a racially concordant provider were more likely to be adherent to the advice that they were given. So this is our team. As I mentioned, racially concordant. And we have a health literacy and wellness coach. That's Ms. Sandra Boyd, who's up there next to me at the top. She's supported by a philanthropic gift, which was we were very fortunate to have. It's a role that initially the hospital wasn't willing to support, but we were able to bargain with them that if we could get philanthropic support for her position and then prove the value of her position, that they would then support her position after 2 years. And so I'm happy to say that they are now funding her position. We have transplant psychiatry. This is Dr. Franklin. He's been with our transplant division for over 25 years and has been a major mentor as we've embarked on this journey. And then we have a dedicated, this is new, and I'm very excited about this, finally have a dedicated transplant coordinator who is actually a 2 times transplant survivor herself. She has had 2 kidney transplants. Our social worker, who I really feel is the linchpin to all that we do. And then we have an outreach and navigator nurse, that's Sharita down there. And so she attends all of our clinics, our ATAP clinics, but she also visits all the dialysis centers that are in those communities on the west and south side and does lobby days, educating patients about transplant and answering questions. We use some data from Lisa Cooper at Johns Hopkins. She wrote a terrific paper talking about centering the patient and the importance of racial concordance and building trust. And so we developed a framework that we follow in our clinic, and we call Keeping It Real. And so we try our best to have racial concordance in that first visit by having this be the group of people that the patients see. We practice empathy and affirmation. And so what that means is we follow Dr. Cooper's advice and we try to limit physician verbal dominance. We just shut up and we listen, okay? That goes a long way to earning trust, and research has proven it. And so the example that I like to give, I had a patient once who felt very strongly that she developed kidney disease because one day she took a long walk in the cold rain and she got sick after that, and then she developed kidney disease. And so, I mean, you could not convince this woman otherwise that cold rain didn't give her kidney disease. She was pretty discouraged about her interactions in the healthcare system because she had been made to feel stupid for holding this belief. And so we all know in this room that that's not what caused her kidney disease, but temporally that made sense to her. So instead of telling her why she's wrong, we'll be like, you know what? I see why you think that. I can understand, why you make that connection. And that's all we say. Just let her tell her story. And then we move into the rest of the visit. So empathy and affirmation. We do our very best to use layman's terms. That also helps to build trust. It helps patients to feel less self-conscious. And again, this is all based on the literature. And then I think the hardest thing for me as a surgeon is to try not to be limited by time. People are shocked when I tell them that in our clinic, I'll spend 45 minutes to an hour with each of our patients. And I'm grateful that we've supported to be able to spend that amount of time with our patients in that clinic, but that makes a big difference as well. Community engagement is a must, and this speaks to that sort of cultural concordance piece and just kind of building street cred in the community essentially. And so this is another part of earning trust. And so as I mentioned, we have our outreach nurse who does dialysis outreach. We have partnership in our transplant center to a business representative who pairs us with different primary care providers and in these communities of color and helps us connect with them and have one-on-one face-to-face visits with them, tell them what we're up to, and helps increase our referrals from these community physicians. We do advocacy. I think that's very important. So we've partnered with the National Kidney Foundation of Illinois and with the American Liver Foundation Great Lakes Division to create shared programs targeting these communities. And then obviously making sure that we're well aligned with our community leaders. And so we've done some tremendous work with Bright Star Church and Trinity Church, which are two of our largest Black churches in the Chicagoland area. And then also with our OPO, Gift of Hope, who has a very strong community arm and is a trusted source in the community as well. Advocacy, as I mentioned, is a must, and I've been happy to work with both Senator Maddie Hunter and Senator Mike Simmons on creating some local legislation. And then Senator Hunter actually named me to be a committee chair for a task force, a statewide task force that she's leading to improve education and reduce barriers to kidney transplantation, and just around education for kidney disease in general. Statewide, and particularly for disadvantaged groups. So moving on now to health literacy. Let me look at my time, okay. You know, the literature tells us that health literacy is a major barrier, particularly in the chronic kidney foundation, or chronic kidney population, excuse me. And you know, what we know is that 35% of our chronic kidney population is represented by African Americans, as we learned early on in the slides. And the limited health literacy is more likely to be present in non-white individuals with chronic kidney disease. What the literature also tells us is that when we get to the point of listing and we get to the point of transplant, that those individuals are more likely to have really good health literacy. And so that may lead one to think, well, maybe we're improving their health literacy as we move along, but actually I would challenge that and say we're actually probably weeding those folks out. And so that's one of the reasons why we decided to create an intervention around health literacy to see what we could do to support patients who are struggling with this. And so I was really excited when we were doing our visioning for the African American Transplant Access Program. We spent a lot of time in the community asking them what they thought a program should look like, what we should call it, what terminology should we use. And we had one session with community leaders, and I met this woman, and she is a firecracker. She has been doing health literacy work in Chicago for almost 40 years, and she was retired. And after we met, she came up to me and she said, Dr. Sims, I'm going to work for you. And we hadn't even created a program yet. We were just in our visioning session. And so I was like, okay, you know, and about a month later, I got a resume from her in the mail, along with a personal statement of why she should work for our program. And so we hired her, and she has been absolutely essential to our program. Her strength has been historically with diabetes and high blood pressure. And so we use her mainly in that space where patients are struggling with weight loss, with food label, with adhering to the renal and cirrhosis diet while still staying true to their cultural food preferences, which is actually really challenging to do. So she helps patients with food journaling and understanding where they're slipping up. One thing I think is really cool that she does too is that part of her practice is whenever she sees patients for initial visit, she does a literacy assessment. So you know, literacy is separate from health literacy. There is some overlap, but a patient can have poor health literacy and still have very high educational attainment. So I think it's important to point that distinction out. But she does a literacy assessment, and she also does a vision assessment. And she walks around with a bag of readers. And what she has found in her practice is that a large barrier to patients being able to be engaged and understand understanding partners in their healthcare is not being able to see And so she fits patients for readers, and it makes a huge difference when they can actually read the papers that we give them, and they can, but they're embarrassed to tell us these things. And so I've learned a lot from her. She works with patients with goal setting and adherence, and as I said, with diet and exercise coaching. She's created a really terrific program where she has partnered with our physical therapy group, and patients will come in, and patients who live in tiny cramped apartments and don't have access to a gym, don't have access to green space. When we tell them that they need to exercise, we tell them that they need to lose X amount of pounds in order to be listed. They really don't have the resources to do that. But she works with PT to create home exercise programs that they can do in their homes, really simple things that they can do in, 20 square feet of space, that has really made a difference for our patients. And then finally, we have psychosocial, and this is our social worker. And as I said, this is where the bulk of our ATAP work is done. And so she is a native Chicagoan. She's linked in with a number of community resources, really helping connect our patients with a number of different things. But the biggest piece I think she has brought is that she's a voice in our committee meetings. And she has a terrific way, a very not judgmental way, a very welcoming way of inviting our committee members to think differently about our patients. And so instead of pointing out the reasons that they're not transplant candidates, let's think of ways we can turn them into transplant candidates. And so, for example, social support is a big, big challenge for our patients, right? If we tell our patients that they need to have someone who can look after them 24-hour days, 7 days a week for 2 to 4 weeks, depending on which organ they're getting, they can't provide that. People can't take that amount of time off of work. We've been able to introduce very creative solutions to our community. Some of our patients are very involved in their church communities. We put together a call schedule with church members. Sister Sue can come in from, noon until 4, and then she has to go to work. Brother Jim can come in and do this, and it took a while for our committee to be on board with that, but we were able to demonstrate success. And so thinking outside the box and helping our patients who are challenged with some of the institutional barriers that we've set up, to try to protect our outcomes, right? This is why we do this. We're doing this, with good reason, but we don't realize oftentimes that it really limits access for a lot of our patients. And so she's been able to help our committee to think about that. And we're actually in the process of studying that. So stay tuned for the results of that study. That's part of our U01 grant. And then the fifth pillar is communication. I'm going to breeze over this because I want to leave time for questions, but working with our media relations team, incredibly important. Getting the word out there, that has really boosted our self-referrals. And seeing a Black face on the news saying, hey, I'm here to provide care for you, really helped patients find the courage to come to Northwestern, which, being honest, centered in an affluent white community, felt off limits to a lot of our communities of color. And now we're seeing more and more of those patients show up. I'm going to skip over that slide for purposes of time. That was just our algorithm. But this is our impact. Okay, so our program has been official for about 5 years. I arrived to Northwestern in 2018. We've seen over 300 patients. These numbers continue to grow. We have actually a capacity problem at this point and have a waiting list that's more than 6 months long. So we're trying to solve to that. And we have waitlisted over 100 patients. We just transplanted our 60th patient last year. We do have a bit of a ramp up that's going on. So some of our early transplant patients are patients who came to us with a dialysis vintage of 10, 12, 17, 19 years. But now we're seeing a lot of the patients who came to us with 1 to 2 months of dialysis get to the top of the list, and finally seeing those patients get transplanted. So we're actually seeing a bit of a rush. We transplanted more than 15 patients in the past few months, so we're really excited to see that growth. This slide shows our waitlist additions, not just for Black patients, but for our white non-Hispanic patients at all. And the reason why I show this slide is I'd like to show that growth has grown. Volume has grown overall for both groups. And so for the folks who criticize a program like this and say, you're taking from one group to give to another, that's not true, actually. And we've seen growth across all demographics in our transplant program. So this is not a zero-sum game in the sense that, we're taking from one group and giving to another. And I attribute this actually to the change in our committee's mindset, because this very same principles that we apply to our disadvantaged Black patients can be applied to all of our patients. We can be creative when we think about social support for all of our patients. And so it's really expanded the way that we think about transplantation for our patients. And then this is our patient care overview. And so what this slide really just demonstrates is that the proportion of Black patients who received a kidney transplant at Northwestern increased from 18% in 2018, 2019 to 26% in 2023. And so continuing to see that growth over time, which has been really exciting. This is one of our manuscripts that's in submission. We just presented this at a meeting. And this was, it demonstrates a couple things. One is that I want to stress, this has not created a segregated transplant program at Northwestern. All Black patients do not go through ATAP. You have to demonstrate a need for one of those different barriers in order to get referred into the program. And so you have to demonstrate a psychosocial barrier, a distrust issue, a health literacy issue in order to get in. And I think it's really important that we don't have a segregated transplant program at Northwestern. So I like to give the example that, I would hope that I myself have good health literacy. I have pretty good resources. Social support isn't an issue for me, so I wouldn't need ATAP. And so it's really important. And so we tried to prove using the area deprivation index that we actually are pulling from the most deprived areas of Chicago. And we were able to prove that with this study. And so you can see the most deprived are the deepest purple, and that's where the biggest clusters of our patients are being sourced from. This just speaks to our expansion with our NIH U01 funding. We are now studying the implementation of ATAP in a completely different location. So Dr. Anthony Watkins is our champion down at the University of South Florida in Tampa, and we're going to be enrolling there starting next month, which is super exciting. And then my final slide that I'll close it out with is that, when we are pitching a health equity intervention, it hits differently to whoever, depending on who you're talking to. So we can use the moral argument, and that may win, many of us over, but we got to be able to speak other languages when we're presenting this, because the moral argument is often not enough. So when I'm speaking to the executive leaders of a major healthcare system like Northwestern, I got to present it from a financial perspective, from a return on investment perspective. And this slide just talks about the cost of health inequity in general. And so this is data from Deloitte, which models the cost of health inequities over the next 15 years. And so right now, they estimate the cost of health inequities to be about $320 billion. And they say that health disparities account for roughly $42 billion in lost productivity every year. If we don't do anything about health inequity, that's projected to reach $100 trillion just in 2040, which is not that far away. And if health inequities have that type of burden on the healthcare system, we're going to see it start to impact everybody, because the cost of healthcare is going to change, access to healthcare is going to change. And so we really need to do something about this. And I love this quote at the bottom from Dr. Theodore, which says, when you address inequities for one population, you raise the health for all populations. And so with that, I will close out and open up for questions. We have some lesson learns. I don't need to read those bullet by bullet, but really, really appreciate your attention. Really excited to finally get here. And thank you very much.
Thank you, Dr. Simpson, for a remarkable presentation. Very inspiring and thought-provoking. We'll open it for questions. And maybe we can monitor the chat box as well. Jason?
It was interesting to see that we've seen that with civil rights, improving the civil rights of everybody. But early on, you get your local community, your local administration to move from who's responsible Chicago and those things, and what are we going to do about it? And that people are conserving by nature of being human as opposed to, well, how do we get to this situation?
Yeah. It's been challenging. I think we've been able to do it with, a lot of one-on-one conversations with starting with division chief, CMO. I've had so many sort of lunch and learns with our staff in our division, just in storytelling, sharing stories of individual patients and helping people to realize that, these are not just numbers. These are not just statistics. These are individuals who have been disadvantaged by many times. You speak about redlining and other social policy. A lot of people aren't really aware of that those things existed and that, this is what created what we're seeing now and the disadvantage that we're seeing. And I think there's a broad thought that, well, if, and we've heard this before, if you just pick up yourself by your bootstraps, and do X, Y, or Z, you wouldn't be in this situation. And, we don't need to create policies to help, this particular population because they did this to themselves or, X, Y, or Z. And so it takes a lot of work and a lot of education to change that mindset. But, we've spent a lot of time, as I said, with different, we've been allowed to use, say, the first 15 minutes of our committee meetings to have, an education. I've met with our social workers one-on-one, the non-ATAB social workers, to, discuss different challenges that they have and sort of share patient stories. And so it's just a lot of education. I will say that initially it wasn't a slam dunk, we'll put it that way. It's something that has, over time. And I will also say that it's kind of a, undulating road, right? So we feel like we're making great success. And then all of a sudden you have one poor patient outcome and we've gone like almost right back to where we started, right? And so, there's that one patient. So now all of ATAP patients, we're going to be very, and so it just takes time. And, but, I overall, it's an upward trend. Mm-hmm. Yeah.
Can we repeat the question on the microphone? Yeah.
Sure. So the question was if we've looked at living donation and all the different challenges that particularly the Black community faces in that space. And we don't have a formal intervention addressed to that just yet, just because we're still in the process of getting this launched, and that's going to take some specific resources. But, this is also something that I think is going to be a culture shift and a culture change, right? Because, I could talk to you all day long about my personal opinion about APOL1 and how we should be using that data to advise our patients and screen our patients. But, it's not just the presence of APOL1, right? There's a whole bunch of environmental things that, that come into play. And so I think that that's going to be a culture shift over time. And, we've been gatekeeping, we've been having a lot of paternalism as a medical community around that, not wanting to harm our patients. Again, a lot of this comes from a space of good, but I think we need to really think about, how we're using this data and how we may be disenfranchising the already disenfranchised. So, we've been having a lot of one-on-one conversations about that. We've had some, of our ATAP patients who have presented with living donors who may have had certain risk factors that we've been able to have, a discussion around and maybe, change the thinking for that individual patient, but we haven't done anything sort of program-wide yet. It is something that we aspire to do, though. Mm-hmm. 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 Right. So the question was, with race being a social construct and sort of, referencing this program and what we try to deliver to our patients, recognizing that not every program is going to be able to provide racially concordant care, how do we bridge that gap in the short term? And so I think this is where I pull a distinction between racial concordance and racial competency or cultural competency and cultural, congruency. So you're absolutely right. We're not going to be able to have racially concordant interventions everywhere we go. But, having education programs to educate on the differences between different cultures, the differences or the different challenges that different groups may face is incredibly important. And so that's one of the journeys that I'm going on, not just for transplant, but for our health system as a whole. How do we identify the different challenges that different groups are facing, from disability, from geography challenges and getting to the healthcare center, to race and language and everything in between? And how do we educate our workforce on those different barriers so that they can really be culturally sensitive when interacting with those patients? And I think that that's key. I think every health system should be looking for ways to do that better. Mhm.
How do you draw the timeline between enticement and offering the
Mhm. No, that's a great question. And, in Chicago, where we have like 6 or 7 different transplant centers, I call it the Game of Thrones of transplant. And so we're very mindful of, trying, the perception that we're encroaching in, somebody's backyard. When our nurse, oh God, what is her terminology? But not the navigator, sorry, the outreach, thank you, goes to the different dialysis centers. When we're on the south side, I mean, that's University of Chicago space. When we're on the west side, that's University of Illinois space. When she does her lobby days, she has nothing that's branded for Northwestern. So it's just pure education. And so we do that on purpose to create a collaborative spirit, say, hey, you get transplanted anywhere, just as long as you get transplanted. We do use the media to advertise what we offer at Northwestern, and we do go and talk with different providers, and it's up to them if they want to refer or not. But when we do our lobby days, we do try to make it very neutral, so that it's not seen like we're trying to grab from other transplant centers. If patients show up to us from other transplant centers, we're very like, we'll give you information, we can list you at both places, we explain to them, the difference of multiple listing within your city versus in different states and stuff like that, and let them choose. And oftentimes they choose, our program because of, what they experience on that first visit. But it's their choice.
Maybe that's one final question.
Mm-hmm.
You mentioned something very important, which is seeing obstacles that the patients face to become a transplant candidate that are inherently structural in the social construct of their either socioeconomic status or where they live. And not uncommonly, this will make them non-candidates, but that becomes an adverse outcome on that population. Your program tries to address that. Have you seen this being an issue in non-ATAP patients as well? Did that permeate into the way the selection committee thinks about those challenges?
I mean, I think so. We've had, I've certainly had situations where I'm on the committee call and I'll advocate for a non-ATAP patient, using the same principles and basically just, helping the committee to see like, okay, yes, this patient is challenged to make it to their appointments or X, Y, or Z reason that was it. If they were transplanted and all of a sudden turned into, someone who we would consider a productive citizen, right, who can work and give back to their community, that will change a lot of those things that we are sort of marking against them. And so I think slowly we're seeing that shift, not just for ATAP, where we have a strong advocacy presence on the call, but just for all of our patients, because people are starting to use the same logic to advocate for all of their patients. And, it's a slow journey, but we're seeing it more and more. So I, would that be, I guess, organ wise, or, I chose kidney because kidney is where you have like just a wealth of literature and information. You have databases that can support your efforts, USRDS, and it was just made it really easy for us to start our research and in our intervention there. Being able to work with dialysis centers is just, the framework was there, and so that's why we started there. Was the lowest hanging fruit, and then we've kind of modeled on the kidney model to reach our liver patients. KP kind of came with our kidney population, but now we're partnering with our heart team and with our lung team. And it's really exciting that Northwestern's first triple organ transplant patient who received a heart, a liver, and a kidney in one operative setting was an ATAP patient.